Good morning, everyone. My presentation is on the Botswana context, on the overview of the Treat All strategy following the launch of the 2015 consolidated WHO guidelines. So my presentation outline will be as follows. There is the context and the background, the modeling and costing results, the implementation, as well as HIV testing, self-testing, and the next steps. So in Botswana, the Treat All strategy was launched in June last year, and the aim was to initiate all people living with HIV on treatment to gain epidemiological control by 2020. So this Treat All strategy meant to us that we were going to be required to identify more additional people living with HIV/AIDS, at least by 2020. So as the number of people on ART increases, the unidentified people living with HIV remaining will represent a smaller proportion of the population and hence require more targeted and additional HIV tests. The HIV testing strategy, modeling, that was developed by the country following the launch of the Treat All, or just prior to the launch of the Treat All. It was developed from November 2015 to May 2016 to establish testing targets across 20 high-level testing strategies. Those were based on their expected reachable population size, testing yields, and costs. So this HTS modeling strategy now needed to be converted into an implementation plan. So through this modeling strategy, the meeting, testing, and treatment targets will require actions and decisions in the design of interventions and the appropriate resources to be allocated. So amongst these interventions was to implement routine HIV testing at other health service sites, such as the TB clinics, STI service points, inpatients, and so forth. This was through the integrated modeling of health service provision. The other intervention is to implement routine HIV testing for key at-risk populations in the outpatient department, specifically targeting men, children, as well as the adolescents. Among the interventions is also to increase testing coverage for sex workers, as well as MSM, and also to implement partner notifications services, as well as to roll out the HIV self-testing and scale up. This was the interventions that were modeled through our testing modeling strategy. So through this strategy, we identified the annual tests for the country, the yield, the patients to be identified, as well as those that need to be linked to treatment over a period of 5 years up to 2020. So the modeling had identified that the number of patients to be identified will actually be declining over the years, beginning the year 2016. This will also apply to the yield that we are to achieve through these strategies. However, yes, the modeling also indicated how much we will need to achieve with the self-testing if it is to be implemented. However, the number of tests to be conducted through all these years is going to be actually higher than the tests or the yields that we will be getting to get through the implementation of this strategy, which means to get whatever you need to get, you need to actually do a lot of more tests. In relation to the modeling strategy as well, we looked at the costs that we will incur as a country as we implement the modeled strategies. We have modeled that with all that you need to do, the actual costing is going to be higher and higher with each and every single year as we proceed. As much as you will be getting the few yields, you have to do that at a very high cost. So implementing the HTS strategy will require key operational actions along the following thematic areas. We had the thematic area on policy and coordination. The progress so far is that the HTC program assessment was conducted in 2016. The national HTS guidelines were also developed to align them with the WHO guidelines. And the HTS implementation plan is also underdeveloped and it is currently ongoing. Serial testing algorithm was adopted by the country through our guidelines, and we also started the verification of the test results adopted in both the HIV policy as well, the HIV rapid testing policy as well as the national guidelines. Thematic area service delivery at facility level. Routine HIV testing is being implemented at all service points, as I had indicated, is being integrated as part of the health service. Testing strategies in communities were also adopted. So far, we have been implementing the following: targeted community-based testing, index partner testing, linkages across the continuum for the key populations, and as well as the home-based care. And also in addition, we continue with our normal routine and VCT models. Program monitoring and evaluation, this is our weakest link. As a country, we have our multiple information systems which are not interconnected and therefore are a barrier when it comes to following on the linkages. So here I'll be sharing with you the testing strategies that have been the outcomes of the testing strategies that have been ongoing in our communities. We have the linkages across the continuum for HIV key populations. This is data for 1 year, October 2015 to September 2016. This is the match we have reached. We managed to reach about 87.7% of the 4,810 targets that we intended to reach. We reached those key populations. We tested them, that is 63.7%. And out of those that we tested, we had a positivity rate of, 559 being tested positives, and among those we had 7% positivity and 21% for the MSM and female sex workers respectively. Now, with the targeted community strategies, the number of people that have been reached with HTC services and number tested by quarter through our APC project in Botswana. These are the quarterly targets and achievements, and overall we have reached 24,329, and those that have tested positive are 1.649. This is now the same project with the different modalities and their yields. The index testing has yielded as the most with 15.7%, followed by the 5.5, which is home testing that is targeted. And the mobile testing, because we continue doing it, is yielded as the 4.9% yield, and VCT yielded the least at 3.5. So the overall yield is bringing us to 6.7%. So continue with the community, these other testing strategies. We have, like I said, adopted the HIV testing. However, we have not yet started implementing it. It's adopted at policy level. We are now in the process of drafting the protocol because the intention is to pilot it before it can be scaled up. So our pilot proposal is at draft stage so that it can inform us how we go about it. So here is a national HIV status cumulative from January to December 2016. This is how the contribution to testing is faring in Botswana. Government is contributing 59%, and we have our NGO partners contributing the remaining part. And now this is our quarterly performance against the first 90 as a country for the year 2016-17. We are now standing at 70.7%. Our baseline was at 70%. So our country positivity rate is 6.2%. So the next steps is to develop and submit a protocol for the planned HIV testing operational pilot, and we are advocating for support, technical and financial and otherwise, from our development partners and other stakeholders. I thank you very much for your attention. Asante Santa, ke a leboga.